is a sort of the basic currency of energy in the body. So we'll have a look at that in a moment. Another prominent theory is the idea that there is activation of immune cells called mast cells. And effectively, these people have overactive mast cells. And so they're mounting a sort of continued immune response and inflammatory response long after any acute infection. Again, we'll look at the evidence for that. And then I'm going to throw in a couple of ideas of my own around dysfunction of something called the HPA axis, or the hypothalamic pituitary adrenal axis. This is the main sort of hormonal system responsible for dealing with stress. And also a simple problem, but very overlooked, which is people who tend to have some sort of breathlessness that then end up actually overbreathing, compromising their well-being in the long term. So let's have a look at the evidence for some of these things, starting with viral persistence. This study, which was published last month in Nature, but was published previously last year as a preprint, so not sort of formally published, but out there on the internet, basically took people who had had acute COVID and then were now asymptomatic, and about 4 months later after the onset. And what they looked for was evidence of COVID virus in the small bowel in 14 people. And they actually found evidence of persistent virus in 7 of these people, so half of them, as well as evidence of sort of immune reactivity, like an immune system responding against those particles. Now, this is a small study and we can't draw too many conclusions from it, but I think what's pretty clear is that even when people are asymptomatic, there's a degree of viral persistence. Okay, so it's still sort of hanging around. What we don't really know is how this might affect someone with long COVID. So, for example, if we had a similar group of people with long COVID, is there more viral persistence there? We really don't know, but it'd be nice to have a study, actually, I think, where we had a large group of long COVID people and compared viral persistence in them with a quite large group of people who have recovered from COVID in terms of their symptoms. But anyway, one of the theories is that the virus has persisted, basically. So another theory that I mentioned earlier, and this has come from people in South Africa, is the idea that we're NAD deficient. So as I mentioned, NAD is a cofactor in actually the mitochondria of the cell. So these are the little engines within the cells, and specifically in something called the electron transport chain, the ultimate goal of which is to produce ATP, this sort of basic unit of energy in the body. So if we're deficient in NAD, we're going to be deficient in energy, basically. And also our tolerance of exercise and exertion will be somewhat reduced because we need sort of NAD to drive the cells. Now, NAD also feeds something called SIRT1. So this is a protein, what's called sirtuin-1. One of the effects of sirtuin appears to be to help dampen the inflammatory response and something called the cytokine storm, which is a thing that causes some people to be very, very unwell when they have acute COVID. But that sort of cytokine activity can continue and cause prolonged symptoms. So if SIRT1 isn't being fed, if you like, by NAD, then it won't work as well. And therefore, there's a sort of overblown inflammatory response, is the idea. Now, one of the things is that NAD can actually be made from tryptophan. So if NAD levels are low, the idea is that the body is sort of stealing tryptophan, which is an amino acid, to sort of bolster its quantities of NAD. One of the problems with that is that NAD is the precursor of something called serotonin, which does a number of different things in the body. It's most famous, I think, for its ability to be mood enhancing, but you could imagine that there may be mood implications from this, particularly sort of low mood. But also serotonin is the precursor of something called melatonin, which is our sleep hormone. So you may imagine, although they don't talk about it in this paper, that one of the potential consequences of all of this, low tryptophan and low serotonin, is also low melatonin, which could then lead to problems around sleep. And insomnia, in fact, is one of the more common symptoms in people with long COVID. So that's NAD deficiency, which we'll talk a little bit about the treatment of that potentially in a moment. So the next theory that we talked about just before was mast cell activation syndrome. So mast cells are a major immune cell, basically, and they contain a number of, if you like, inflammatory substances. about 1,000 of them, the most famous of which is something called histamine, which we know is implicated in sort of allergic responses, but it's just one of a number, literally hundreds of chemicals. Now, it's thought that up to 20% of the population is prone to having mast cells that are a bit sort of trigger happy and can release these sort of inflammatory markers quite readily. Now, because these inflammatory markers are many and varied, the symptoms of mast cell activation syndrome can also be many and varied. And it's thought that many people go many years without a diagnosis or no diagnosis at all because of this. And this condition has not really been recognized until relatively recently. Now, this paper sort of partly talks about that, but it's also really talking about that it appears that many people with long COVID have problems that are very similar actually to mast cell activation syndrome, with the idea there that possibly they've developed it, mast cell activation syndrome, as a result of long COVID, or it was there sort of bubbling away in the background. And now, if you like, COVID has caused this thing really to come to the fore and cause very obvious sort of persistent symptoms. In fact, COVID can gain access to mast cells through what's called the ACE2 receptor. And this is a direct point of contact and attack for the virus, which could cause widespread problems with mast cell activation. The authors of this study note that there's quite a lot of overlap between the patterns that you see with COVID-19 sort of inflammation, as well as the inflammation that you see in mast cell activation syndrome. And so their suggestion is dysfunctional mast cells actually may underlie, first of all, severe acute COVID, but also, most importantly for this presentation, sort of chronic long COVID symptoms. They actually produce a table in this paper where they list all of the kind of most common symptoms of mast cell activation syndrome, and then boldify, as you can see here, the ones that overlap with long COVID symptoms. And there's quite a lot of overlap. So if I was going to represent that graphically to you, I'd say if this is long COVID, mast cell activation syndrome looks a bit like this. So they're not a perfect match, but there's quite a lot of overlap here. And so there is some thought that in certain individuals, mast cell activation or overactivation, if you like, is a underlying factor. We'll talk about treatments in a moment. So one thing that I'd like to sort of throw into the mix here is that I've seen quite a lot of chronically unwell people over the years. And one of the issues is that some people, when they're unwell, can develop a bit of a problem with overbreathing, or what we call hyperventilation syndrome. Now, to understand this, we need to understand a little bit about basic sort of respiration. So, of course, when we breathe in, we essentially absorb oxygen through the lungs into our bloodstream, where it attaches onto red blood cells, actually a protein called hemoglobin. And the red blood cells are shunted around the system for that oxygen then to be delivered where it's required, the brain, the muscles, the spleen, the pancreas, or whatever. Now, when we use oxygen, as you know, we create something called carbon dioxide. And the general thought is this is a sort of waste gas that we're trying to get rid of. And there's an element of truth to that. But what it sometimes causes us to forget is that we need carbon dioxide in the bloodstream. We want some. We don't want too much, but we do want some. Now, one of the reasons for that is that carbon dioxide is really important for the delivery, the efficient and effective delivery of oxygen into our tissues. And the more carbon dioxide we have, the better oxygen basically leaves the red blood cells and then gets into our organs and tissues. So one of the issues for some people is that they can tend to sort of overbreathe, breathe a bit too quickly, if you like, a bit too much. And what that can lead to is low levels of carbon dioxide in the bloodstream. Now, if this is very bad, okay, and people, for example, are quite anxious or agitated around this, we can get to the state where they end up with what you might call a full-blown panic attack. Okay, so one of the reasons for that relates to this overbreathing. It can change the sort of psychological state. Calcium levels can drop in the bloodstream, which can cause constriction, for example, of blood vessels, as well as neurological symptoms. Now, just to show you that in sort of graphical terms, here's the oxygenation of someone's brain breathing normally. Here's the same person overbreathing. So this is essentially hypoxia, so low oxygen levels in the brain of someone just as a result of a change in breathing pattern. Now, this is quite acute, okay? For example, this could be a panic attack, but you may know that one of the standard treatments for panic attacks is just to get someone to breathe in and out of a bag held over the nose and mouth. And the whole point of that, as you may know, is basically to concentrate carbon dioxide. You're getting people to rebreathe air, which reconcentrates carbon dioxide in the system. And that, by the way, tends to work like a charm for people with a panic attack, because you could argue their fundamental problem was they were overbreathing and then induced low levels of carbon dioxide. So most people are not having panic attacks, but many people are overbreathing, okay? And this is something that is not that uncommon in people with chronic illness. Now, I don't know, because I haven't seen a whole bunch of people with long COVID. But when we think about it, you know, fundamentally for many people, it's a respiratory illness, at least to begin with, okay? And when people have a respiratory illness, they tend to feel breathless. And as a result of that, it tends to sort of push sort of over-breathing, if you like. Now, the over-breathing can then lead to chronically low levels of carbon dioxide, which chronically, in the long term, compromises oxygenation of our tissues and organs, you know, which is a fundamental issue because, you know, we can have all of the, you know, right chemicals in our body and mitochondria that we like, but if we don't have oxygen there, it's a little bit of an issue, as you can imagine. So one of the problems with low carbon dioxide is that it reduces people's tolerance of carbon dioxide. And carbon dioxide is the major driver of the need to breathe. So, for example, if you hold your breath for an extended period of time, the drive to breathe again doesn't come really from a lack of oxygen. It comes from a buildup of carbon dioxide. But if you don't tolerate carbon dioxide particularly well, you're going to tend to feel breathless relatively easily. So do you see the problem here? So I don't know. I wish I could tell you that I'd seen 200 patients with long COVID and this is very common in them or whatever. And I can't tell you that. What I can tell you is that overbreathing is quite common in people with long-term illness, particularly respiratory issues. And it's something that I think should probably be looked out for. There's some standard questionnaires for overbreathing that if you're a practitioner or you work in the area, you might find helpful. The most commonly used is something called the Nijmegen questionnaire. There are a few symptoms in here that sort of overlap, I think, somewhat with some of the long COVID symptoms for what's that worth. And here's another questionnaire, which in general life, I find a little bit more useful overall. It's called the Self-Evaluation of Breathing questionnaire, something that you might want to use as a tool if you suspect overbreathing. Another thing that I wanted to talk about is the whole concept of, you know, post-viral fatigue and what some people call burnout, you know, and what's really sort of going on there. So I have a feeling, although I don't know, that this is quite likely going to be a factor in at least some people with long COVID, okay? So it relates very often to what we'd call the stress response, which has two elements to it. One of which is neurological and involves something called the autonomic nervous system. So that's the part of the nervous system that controls sort of unconscious automatic things like heart rate and breathing rate and digestion. Now, we're not going to talk about that. It's not quite as relevant to this discussion as this other part, which is more hormonal in nature, that involves something called the HPA axis, or the hypothalamic pituitary adrenal axis. So I mentioned that earlier. So what is that? Well, it's this. So stress is sensed in the brain in something called the hypothalamus, which sends a signal to the pituitary gland at the base of the brain, which sends a chemical signal to the adrenal glands that sit on top of the kidneys. Now, in response to any stress, the adrenal glands then produce certain hormones. One of them, I suppose, is obvious. It's adrenaline, also known as epinephrine. And the other one, which is actually more important, is called cortisol. So what do these things do? Well, they, for example, you know, adrenaline can speed heart rate, cortisol raises blood sugar levels. This is really all about providing energy into the system. Now, if you look at cortisol levels over a day, they generally look like this. So what we're looking at here is the right-hand graph, and specifically the black line, which you'll see is high at the first part of the day and then comes down over the day to be low at night. So this is the cortisol level, a typical cortisol level in someone who's normal and healthy and not, for example, unduly stressed. Now, cortisol gives us energy, right? So this is what most people want. They want plenty of energy during the day and not too much at night. The problem is over time, because of stress and maybe chronic illness or a variety of factors, this system can weaken. Okay, and for example, in someone who's undergone a long-term illness or long-term stresses, we very commonly see that the ability to secrete cortisol normally falters somewhat, and they can actually end up in a situation like this, where there's really not very much cortisol there at all, and also the normal rhythm, that high to low, has essentially been lost. So this is sometimes referred to as adrenal fatigue. And this is a major cause of why people are sort of chronically tired. This is a major underlying factor in chronic fatigue. I found it to be a major underlying factor in post-viral fatigue. It is also a major factor in what some people refer to as burnout. So other than fatigue, are there any other features of this? Yes, a very common feature is not just that people are tired, is that they get tired very easily. They don't have to do much to be pushed backwards. So for example, just a little bit more physical activity, a bit of mental exertion, a small additional stress on whatever they're dealing with at that time can be enough for these people to really feel it, basically. Brain fog and mood disturbance are very common in these people. Very often people have low mood in this situation. They can have anxiety, that's entirely possible, but usually it's like all the energy is low, including mood. Hypertension, so low blood pressure that particularly drops on standing, is another thing that can happen in these individuals. Generalized aching is not uncommon in these people. And finally, from a sort of food perspective, these people may crave either sweet and or starchy foods. That's not that uncommon. Now, many of these symptoms are consistent with the picture that you quite often find in long COVID. And my guess is that a proportion of people with long COVID have a degree of adrenal fatigue, and it would be a good idea to look at that and possibly address it. It's a kind of for me, this is quite foundational. So if someone has adrenal fatigue and it's not dealt with, it's very unlikely that they're going to make much of a recovery very quickly. It's really sort of fundamental to people's well-being. Okay, so let's think a little bit about treatment now and what we can do about it, starting with diet. Well, one of the things that we talked about earlier was the idea that one of the underlying factors in long COVID might be what's termed mast cell activation syndrome. Now, with mast cells being activated, very often there are relatively high levels of histamine in the system because histamine basically comes from mast cells. And so some people have advocated and found great success with actually a low histamine diet, which means avoiding foods like these here, alcohol and the like, and concentrating mainly on foods that are relatively low in histamine. Now, if I can just add something to this, assuming for a moment that someone's got a degree of adrenal weakness, some adrenal HPA related issue. What I've found with those individuals that overall, the sort of diet that suits them is one that isn't too what I would call light. So I know we advocate sort of fruits and vegetables or whatever, but usually a diet very rich in those foods doesn't really do it for those people. What's normally required is a bit more protein and fat. So, for example, avocado or Greek yogurt or nuts and seeds and meat and fish tend to suit these people a lot better, as does, by the way, some salt. So some people with adrenal issues tend to have lowish blood pressure, which tends to drop on standing. And those people generally feel better when they have a bit more salt in their diet, which seems to help, if you like, support their blood pressure overall. Now, I know salt is something that we're often advising people not to have. Actually, the evidence for the benefits of a low salt diet are, well, they're almost non-existent, actually. So I don't worry too much about it in terms of how much salt people eat generally. There's the odd person that might want to avoid it, but generally it's pretty safe. And there are some people who positively benefit from a bit more salt. So if you wanted to put this all together, it would be a diet based on, fresh meat and fish and eggs, some nuts and seeds, some vegetables and that nature. And that does tend to suit people broadly. but also this sort of low histamine element of it may have additional benefit for people with long COVID who have, for example, an element of mast cell activation syndrome. Looking at supplements, at the top of the list, probably niacin. So niacin, also known as nicotinic acid, basically helps the body make NAD. And NAD deficiency is one of the prominent theories around what causes long COVID. Now, according to the South African researchers and the authors of that paper that we looked at earlier, this is the key, really, to getting a lot of people with long COVID feeling better. So have I trialed this in practice? No, I have not. But I think, bearing in mind that niacin is a cheap and widely available supplement, it is worthy of our consideration. Now, it's relatively safe, niacin, although niacin tends to cause flushing in the system. So usually the advice would be to start on quite a low dose, say 25 milligrams, once a day, and then once someone is accustomed to that, to build up to twice a day, 3 times, 4 times a day. And normally people, a sort of standard dose would be in the order of about 100 milligrams per day, split up into these 25 milligram doses taken 4 times a day, basically. So another supplement worthy of our consideration, I think, is vitamin D. Now, vitamin D has received quite a lot of attention, partly because low levels of vitamin D are quite strongly associated with increased risk of COVID, severe COVID. There's also a study that came out of Spain some months ago where they gave people who were admitted to hospital high dose vitamin D derivative, actually, and found it dramatically reduced the chance of them getting very unwell and ending up on ITU. So there may well be something in this vitamin D and COVID thing. So it's immune supportive, we know that, but it also has anti-inflammatory effects, and basically people with long COVID are hyperinflammatory. But it also supports serotonin synthesis and can help mood, and is a mast cell stabilizer. So for a variety of reasons, vitamin D, I think it should be probably in the mix if we're thinking about supplementation, and sort of fairly good doses, but certainly not excessive, will be in the order of 3,000 to 5,000 international units. Now, vitamin C supports the immune system, but it's also a natural antihistamine. So those advocating for nutritional support for people with mast cell activation syndrome would generally recommend about a gram of that, so 1,000 milligrams 3 times a day. Zinc supports SIRT1, so sirtuin-1, which we talked about with regard to NAD deficiency, because lack of NAD will essentially inactivate SIRT1 and allow a more inflammatory state overall. So because zinc helps SIRT1, throw it in, get SIRT1 working better, calm down the cytokine activity and reduce inflammation is the idea. Selenium, one of its effects appears to be as a mast cell stabilizer. So a smallish dose of that can be helpful, as well as quercetin, which is also a mast cell stabilizer and also has anti-inflammatory effects at a dose of about 500 milligrams a day. Now, this is a bit of a stack, but most of these things are relatively available and not particularly expensive either. There are much more expensive supplements out there. These are not generally, and I'm not saying everyone should be taking them all, and I'm not making a medical recommendation. But the sort of the word on the street is that particularly niacin, but some of these other supplements can be very helpful to people with long COVID. Let me throw in one of my own. It's a herb called Rhodiola rosea, also known as Arctic root. And when I use this in practice, of like if I'm advising this, I'm generally advising it for people who have evidence of adrenal fatigue. So it's generally used in practice for people that have conditions that are like, fatigue and problems with work performance, and, people that don't do well around sort of physical or even intellectual cognitive strain, basically. So people that are quite like people with long COVID, actually. So it's what's known as an adaptogenic herb. So it helps people basically adapt to stress. And it seems to work mainly through its influence on certain brain chemicals, including what we call the monoamines, which includes serotonin. And that's one of the reasons why I think it may have some value in long COVID, because one of the things that's probably true, with at least some individuals with long COVID is that they tend to run low on serotonin, and bolstering that can be generally helpful to their overall state, their overall well-being, as well as mood specifically. There's quite a lot of evidence supporting rhodiola as a herb for treating a variety of things, including things like anxiety and mental performance, fatigue-related issues, cognitive stress, and mild to moderate depression. So overall, bearing in mind how a lot of long COVID people present, and given my suspicions about their, HPA axis functionality, I would say it's worthy of consideration. Now, with regard to medication, the medications that are generally advised are essentially for people where we suspect there would be some mast cell activation syndrome. So what are they? Well, mast cell activation syndrome is characterized basically by very often quite high levels of histamine. That's the whole point of the low histamine diet. So how about some antihistamines? Well, again, the word on the street is that these can work very well with individuals. Now, usually these are advised once a day. And it seems with people with long COVID, these need to be taken a little bit more frequently. So maybe 3 or 4 times a day. But many antihistamines that might be effective for people are available over the counter. Certainly they are in the UK. It might be different where you are, but I suspect not, because these drugs are generally regarded as safe and are available over the counter. Now, there are some antihistamines that may be beneficial that require prescription. Famotidine would be an example of that in the UK. And there are also other drugs that stabilize mast cells. There's something called chromalin that does that. Again, in the UK, this is needs to be prescribed, but again, worthy of our consideration, I would say. So we've looked at some of the dietary ideas here, basically relatively protein, fat-rich diet, low in histamine. That's generally helpful. We've looked at some supplements, notably niacin, vitamin D, zinc, selenium, quercetin, for example. And we've also looked at some of the medications that we're seeing here. So essentially antihistamines or things that stabilize mast cells. So I just want to return to something that I was talking about earlier now, which is this idea that some people who are chronically unwell, particularly with a pulmonary respiratory disorder, tend to overbreathe. So a fundamental problem, just to remind you, is that these people, because they've been overbreathing for a period of time, have become intolerant of carbon dioxide and are now chronically breathless. Okay, they just, even when carbon dioxide rises just a bit, they can easily get breathless, which drives further overbreathing, and so the cycle repeats. So one of the approaches that could be helpful for these people is to get them used to carbon dioxide again. And the way to do that is to basically get them to hold their breath. So breath retention exercises can be very helpful for these people over time. There's a form of breathing technique known as Buteyko breathing that could be helpful here. There are more traditional forms of breathing like pranayama, in the sort of yogic sort of Eastern tradition that can be helpful. And what I've found overall is that people who've been chronically unwell that are exhibiting some symptoms of overbreathing very often benefit significantly just by retraining their body to tolerate high levels of carbon dioxide through one or more of these techniques, basically. As a simple tool, there's an app called Apnea Trainer. This is actually designed and intended for free divers. It's not why I would generally recommend it. But basically what it has is a number of different functions within it that allow people to gradually breathe up their breath holding sort of exercises, So you might start, for example, on breathing exercises where you breathe in for 2 seconds, hold for 2 seconds, breathe out over 4 seconds, and then hold for 2 seconds, for example. And then once you're used to that, you can go to breathing in for 3, holding for 3, breathing out over 6, holding for 3, and then up to 4, 4, 8, 4. And you continue in this way, gradually getting the body more and more tolerant to carbon dioxide, which then increasingly improves breathlessness and overall oxygenation. So it's a simple approach, but can be quite effective for people who have sort of lost their exercise tolerance related to overbreathing. The other good thing about this app is that in between phases, it vibrates if you want it to. So that means it can be done completely silently if you wish, basically. There's a good book really about the idea of overbreathing and breath retention, how that can be helpful, called The Oxygen Advantage, written by an Irish author called Patrick McEwen, if you wanted to look more into that. Now, the final thing that I want to talk about is this app. So this app is a British invention, basically, and it's really designed in response to this sort of phenomenon that I completely agree with. You can have two people with the same diagnosis that have very different sort of underlying processes going on there. I mean, it's possible, for example, for someone with long COVID to have a major problem with NAD deficiency, another problem with almost identical symptoms to have their fundamental problem in, I don't know, mast cell activation syndrome, or, for example, adrenal fatigue, or hyperventilation, or whatever it is. Okay. So very often what you find when treating people who've been chronically unwell is that usually different approaches work for different people. You probably know that, okay? But very often in clinical practice, you're sort of guessing as to, what might work. You're using a little bit of experience to try and sort of tailor the treatment according to what you think you're seeing in front of you or what the test results are showing you. So someone in the UK took this basic idea and decided to develop an app that allowed people to log their symptoms and their progress completely anonymously, and that information would be pooled. And the idea is the app is essentially using the symptoms to, if you like, group people together into symptoms and how things present, and then from what's coming with regard to how people are responding and what they're finding useful, that app will then feed you information about what is generally helpful for people that have your particular brand of any condition, including long COVID. So I don't have any direct experience of this app myself, but it strikes me as a very, very good idea and possibly a really useful resource for people, if you like, sort of going forward in terms of helping them sort of self-care and direct their own care in a way that's a little bit less scattergun than just going, try this and try that. So I fully endorse it. By the way, it's free as well. So that's another reason why we may not have too many barriers to using it. But again, it's completely anonymous. Don't have to put any names or those sort of details. So you can just put in, for example, if you wanted to, your age, for example, some other demographic details that don't identify you. And then for predominantly what it's gathering is data on your symptoms, not anything else. Okay, so let's stop there. We're about 1:45, and let's take some questions. Are there any?
Thank you, John. There is a question by the chat side that says, what objective clinical test can measure or diagnose chronic over breathing, please? I'm not. If you can check it, that group, your chat.
Well, overbreathing is not something that you can really diagnose with sort of clinical tests. It's really a symptom-based diagnosis. It's how it presents clinically. So the best that we have, along with a bit of experience in the area, is the questionnaires. Now, those questionnaires are not really diagnostic. They're not. And if the score is 23, that absolutely proves the point. But it gives a good, strong sort of indication. So there is no clinical test as such. You have to go on symptoms. A bit like, by the way, if someone were to present to you in the middle of winter with a runny nose and a feeling of heat in their head and a scratchy throat, you'd say it's a cold. It's a bit like that. Would we test for it? No. We'd go on symptoms.
Thank you, John, for that response. There's another question that says, what criteria can be used to assess a pre-employment medical for a high-risk job post-COVID-19 condition?
What does that mean?
Maybe let me ask Agnes. I know that's Sister Agnes. If you can unmute yourself and probably give more detail to your question. Sister Agnes. She might probably struggle with Agnes, you can ask your question.
My question is, what criteria can be used to assess a pre-employment medical if that person gives history or he is a post conditions?
Yes.
Now I've got this pre-employment here in front of me.
Yeah.
And then according to the main job specification, is going to do a critical job task.
Yeah, sorry, I don't know anything about that. I have nothing to do with occupational health.
Yes,
It's just not my thing.
It could not be a criteria for rejection of other things. What should I consider?
I don't know. Occupational health is just not.
Maybe let me ask Dr. Mpofu to and Dr. Neil to probably respond to that particular question.
Hi, thank you. It's Neil here, if I may. I think we will go into a little bit more detail in the next lecture. So without boring everybody to death, let's rather tackle it, giving an overview and then things to consider, if you wouldn't mind.
Thank you, Neil.
Thanks, Neil.
Sister Agnes, we'll consider your question and respond to it when Neil makes his presentation.
Thank you very much. Thank you. Thanks.
Thank you.
Thank you. There's a question there for you, Dr. John. What percentage improvement are we likely to see with the supplements or stroke medications that you spoke about in terms of a long COVID condition? What percentage improvement?
Yeah, okay. So I have no direct experience myself. So I'm going on what the people who advocate these treatments say about things like, I don't know, treating people with niacin for NAD deficiency, or treating people with a low histamine diet and mast cell stabilizing supplements or whatever. And I have no reason to disbelieve them, by the way. I'm not that cynical. So the improvement for many people is considerable, stroke complete. I mean, they feel transformed by the treatment. So there are some people, there's no panacea, so nothing works for everyone. But the reason that we've talked about these approaches is because they can make a very clear and tangible difference to people. I mean, I've heard stories about people going on a low histamine diet, just that, and being transformed by it. Other people just starting something like niacin, tidying up their diet a bit, and again, being transformed by that. So, you know, different approaches work for different people. It depends on the underlying mechanism and how responsive that person is, for example. But let me put it this way, the word on the street is there's considerable potential here for people to feel significantly better, stroke recovered from quite simple approaches. Now, my own experience, by the way, when we think about things like overbreathing and, for example, HPA axis dysfunction tend to take longer for people to improve. You know, if you've been chronically overbreathing, you don't suddenly stop overbreathing overnight. And if you've got, for example, adrenal fatigue, that does not go away overnight. These things tend to take weeks or months to resolve. But with regard to those other approaches that we were talking about, MCAS, so mast cell activation syndrome, and NAD deficiency, very often with the right approach, these people seem to recover actually very quickly, feel better very quickly. And so I think there's quite a lot, at least for certain people, to be optimistic about there.
All right. Thank you, John. I don't see any other question. Let probably give your last remarks. If a question pops up, then I'll give you a. Maybe Sarah, you want to speak. Unmute yourself and speak.
Good, thanks. I didn't see a hand there option, but I just wanted to make a quick comment about that I was happy to see, Dr. Briffa, that a lot of the sort of hypotheses that you discussed here are things that are being reviewed in active patient support groups, particularly the Slack group, and then also various sort of social platforms like Twitter. And I just think that the reason I asked that question about sort of objective data is because we're all sort of feeling around in the dark in terms of what we're experiencing. And I think particularly because of a lot of our symptoms are in the subjective realm versus the objective realm, there's a huge problem sort of with our symptoms being somewhat categorized as psychiatric, when we really have almost no research, spelling out the underlying pathologies that we're experiencing. So I just want to say on behalf of the patient community, that everyone is trying all these different things, but I mean, very few people are getting total relief, and just our need for research to sort of give us some answers about, we have all these things that it might be, and what is the combination that's happening with each individual, knowing that it's probably different and multifactorial. But anyway, it was nice to see that review of somebody who's clearly sort of searched everything that we're also frantically searching to try and fix ourselves.
Yes, so thank you for that, Sarah. So if I can just add a couple of comments of my own on what you've said. First of all, I'm a great believer in looking at the research, but the reality is with this condition, as you know, there isn't that much research. And even if there was, I wouldn't stick slavishly to it. And that's because it's quite a complex condition that can manifest in different ways and have different treatment strategies depending on what's going on underneath for a particular individual. So with that in mind, ultimately in clinical practice, you're left with essentially one person with a set of problems. And that how you treat that person or how that person may treat themselves can be informed by the research, but it doesn't dictate it, if that makes sense. So we're always going to be in a situation where you have to take a bit of this, take a bit of that, listen to what people are saying, and then try and piece something together and work out, as to the best of one's ability, what's going to be the right approach for any individual. Okay. Number two, I'm generally very resistant to the idea that anyone with unexplained symptoms where we don't have a definitive test or whatever is just put into this, well, it's clearly a psychiatric issue. I'm not saying there aren't psychological and mental problems associated with long COVID. Okay, I know you're not saying that I was, okay, but I just want to make this point very clearly. But I think what happens is, when we can't explain something, then we'll go for some sort of junk sort of diagnosis, really, where we just say, well, it's because you're older, or, you're stressed, or it's psychological, or whatever. I think this happened with chronic fatigue, by the way. And chronic fatigue has real things underlying it, real pathological processes very often. But for many, many years, it's just like, well, you're just depressed, aren't you? Isn't that the issue? Do you know what I mean? So I'm a bit resistant to that, and I'm not saying it's not important to look at psychological factors, and maybe there's a diagnosis of anxiety or depression in there. But usually what's happening with these conditions is there are things that have not been identified, not even been looked for, and then we just sort of default to this, it's clearly a psychiatric problem. And very often what I found is, particularly with individuals that have been put into that category, working around, approaches, for example, similar to the ones that we've been looking at in the session, can be really helpful, and way more helpful than just saying, you better take something for your serotonin, basically. So thank you very much for your comment.
Thank you, Dr. John. Let me give you the your closing remarks, probably 2 minutes, and then we can move to the last speaker for the day. Your closing remarks, Dr. Briffa.
Yeah, so my closing remarks are these really, long COVID is obviously a real thing. And I think significant numbers of people have it. At the moment, I don't think it's particularly well understood. But clearly, when you look on the ground with what certain practitioners and certain patients are saying, there is considerable advances being made in that area, even in the absence of objective scientific research. And I'm always mindful of the fact that fundamentally we should look there first and not to the research first to find our answers. Ultimately, as I said just a moment ago, in real life, you're faced with one person, that person living with themselves with their issue, and very often what they will find will work for them has not been informed by even published research necessarily, just something that's maybe garnered much more sort of informally, including from a Slack group, for example. Personally, even as a medical practitioner, I'm all for that.
Thank you, Dr. John. I think we benefited from your exposure of this topic. Thank you so much. We will send the presentation to all the delegates. It's been a pleasure having you, Dr. John.
Thank you. Thank you for having me. Thank you, everyone.
Thank you. Dr. Neil, kindly put up your presentation. Dr. Neil.
All right. Yeah. Thank you very much. I'll put it up and then just give me a second. How's that? Right. Okay. Mhlandla, can we go ahead?
Yes, you can go ahead. The presentation is up.
Okay, thank you.
Come close to the mic. You're a bit faint.
Okay, yeah. Just because of the bandwidth and so on, I most likely will. I'll put my picture back up a little bit later. But yes, all right. So yes, I want to congratulate. Oh, sorry, there we are. Okay, you can see my screen. All in order.
Yes, we can see your screen, Neil.
Excellent. Yeah. So yeah, thank you, Dr. John, also for pointing out, and I cannot stress it enough, is that it's okay to say I don't know. We don't know everything, and we learn every day from our own experience and observations in practice, as well as, of course, what we read. And I can remember in the early days of HIV being a student at one of the academic hospitals, studying. We didn't know anything about HIV, and certainly we've come a long way. So I'm going to share some thoughts with you on occupational health, give you a little bit of an overview and so on, and then proceed later on something to think about and conditions and things that we should consider. So occupational health has actually, in my mind, two answers that one should two questions that we should answer. The one is the work making me sick? Okay. And the other one is, am I actually fit enough to work? Do I have the attributes to be able to perform this job? Those are the two answers that we need to answer. So if we look at it, this is based on South African legislation, but if we look at a little bit, the first question is, who may perform the examination, And if we look at the legislation, depending on the regulations and so on, there are various types of industries which will allow in South Africa, in a regulated country, for occupational medical practitioner, OMP, to do the examination, or an occupational health nursing practitioner to do the examination, or both. And in certain instances, a general practitioner. All right. And if you look at the conditions and the regulations, you will notice that mainly the ones that could have severe consequences of the individual declared fit, and should something go wrong, the consequences could be quite severe. So those are the conditions that will necessitate an occupational medical practitioner to do the examination. As we see with seafarers, the mining industry, as well as with manganese and manganese poisoning, which requires quite a detailed neurological examination to take place. All right. Just yesterday, I had a request from a company where they did medical examinations through, with no disrespect intended, but through an occupational health nursing practitioners, but they are required to work with asbestos. And now they need to do everything over again, and they didn't do spirometry, they didn't do x-rays, etc., etc. All right. It's just a little bit of background. And unfortunately, I was not able to attend the meetings earlier, and my colleagues maybe referred to this in more detail in the earlier sessions. But if I look at the news guidelines, we'll get to that as well. The National Institute for Health and Care Excellence, they look at acute COVID-19, so signs and symptoms of COVID-19 for up to 4 weeks, and ongoing symptomatic COVID-19, the signs and symptoms of COVID-19 from 4 to 12 weeks. All right. So then the post-COVID syndrome, signs and symptoms that develop during or after infection consistent with COVID-19 continue for more than 12 weeks and are not explained by an alternative diagnosis and syndrome. And as I've mentioned earlier, it's okay to say, I don't know. It's okay to defer or to wait with your prognosis or your fitness certification, requiring you to get more information, from another, colleague, or alternatively requesting additional assessments, for instance, an occupational therapy report. Long COVID is commonly used to describe signs and symptoms that continue or develop after COVID-19, and it includes both of the above two that I've already mentioned. All right. Just go to the next slide. All right. So it requires a comprehensive history, and a history of suspected or confirmed COVID-19. And it's also important to note the nature and the severity of previous and current symptoms, the time duration of symptoms since the start of acute COVID, and of course the history of all other health conditions, including, we talked about psychiatry and so on, but a comprehensive medical history and time spent on this aspect cannot be overemphasized. All right. Now, a lot of the information on these slides are from the NICE guideline. You'll also notice that the symptoms are highly variable and is wide-ranging. The most commonly reported symptoms include the following, and we'll go through that. And I'm sure more will be added, as we go along and as we get to know more about COVID-19. Okay. So if we start off with the respiratory symptoms, and as I've mentioned, some of my colleagues may have added more even to this list. But we talked about the breathlessness with Dr. John, referring to the apps there and techniques of training to get rid of it. So we need to consider if this is a complaint of the employee sitting in front of her. Is he going to work with a respirator? Are there chemical irritants involved? Either acid fumes, or it might be spray painting, it might be organic solvents. Is there physical work requiring strength and endurance, like for instance, a construction worker? Is there underground mining, or is there engineering involved, needing the carrying, lifting, so on of heavy, components? The same as for coughing, basically the same. It's very difficult if you sit with a respirator, you need to go and work in a confined area, and you start coughing, you will be inclined to want to remove the respirator. And the same is true for, exposure to chemical irritants, dust, and of course, heavy physical work. If we go to cardiovascular symptoms, there is a feeling of, it might be subjective, but the feeling of a tight chest. And again, we need to consider, respirator use, chemical irritants, physical work. Does it require endurance? Is it underground? Is it engineering? Is it welding fumes with a welding mask? Are they exposed to a heat area like in a foundry? Chest pain, palpitations, very, very difficult if there's a history of COVID and the employee mentioned these things. And I'm sure you'll understand that one of the implications with COVID is it might take longer than just one assessment to do the adjudication and to provide a certificate of fitness. That might take assessment by either additional tests, which we'll get to, or an opinion by a colleague or another specialist in a certain field, If we look at fatigue, always a very difficult one to subjectively measure. We are involved with some of the fatigue management programs on the mines, whereby there are internationally benchmark tests that actually they first go through a questionnaire, a first round of assessments, and then another, validated questionnaires, a second round of questionnaire on tests, and then what we do then, those that require, for instance, a sleep study, we perform a sleep study. All right. Looking at obstructive sleep apneas, that not may be the cause of fatigue, etc., etc. So when it comes to COVID, it might be necessary to exclude other physical causes of fatigue. And it might be something that, it might be a hemoglobin, it might be looking at sleep itself. So it requires quite a good, knowledge of the working conditions and so on, and also look at what the differential diagnosis of fatigue is and exclude it. And as Dr. John was also saying earlier, not just put it down to stress or psychiatric reasons and so on, All right, fever, maybe a little bit easier to quantify and to prove, with a thermometer. Pain can be, muscle pain, myalgia. If you complain of general pains, and you need to go and work 8 hours and longer shifts underground, where it is, in the high 30 degrees and maybe even higher, that will be quite difficult. Okay. All right. Neurological symptoms include, for instance, cognitive impairment, so-called brain fog, loss of concentration and memory issues. And this is extremely important, where clarity of thoughts are required. And one might need to consider doing a mini-mental here, something like the Falstein mini-mental test. It might be a requirement, okay? There are alternative tests, and we'll get to this, where I don't know how many of you have heard about the HIV, International HIV Dementia Scale, but I don't say use that, but there might be a need to develop something like that, through research, and provide us with a tool actually to quantify cognitive impairment associated with COVID-19. Of course, headache, one of the symptoms, and the physical conditions where it might be quite, you need to consider whether you need to declare fit or not. Sleeping disturbances, we talked about that, but it'll be of extreme importance, especially for those workers, performing shifts, shift work. And of course, your long distance truck drivers. I mean, there's hardly a day that I don't read or get to know about a head-on truck head-on collision, on the roads, So that's quite important. Then also, some complain of peripheral neuropathy type of symptoms with pins and needles, which might be the vulnerable population will be working with vibrating tools, and certainly also whole body vibration. And then also where dizziness is concerned, is the individual working with heights? Is it a construction worker? Is he operating mobile machines and vehicles? In other words, will the safety of other people or are other people at risk as a result of the dizzy spell that this guy might suffer from? And delirium, from what I understand, it's more so in the older population. All right, but again, you might consider doing a mini mental as part of your assessment. All right. Then there's the gastrointestinal symptoms, abdominal pain, nausea, diarrhea. Consider the access to a toilet. Is it close by? Can he go? Can't he go? And then also anorexia, reduced appetite, more so in the older population, but extremely important if you're dealing with somebody with diabetes, to under normal circumstances, his diabetes might be under control, but as a result of changing in these appetite, you might find that he might develop episodes of hypoglycemia. If we get to the musculoskeletal systems, this can certainly be musculoskeletal conditions could be worsened by cold environments, working in a cold storage. It might be a forklift driver, spending long hours within a cold storage facility. And also, and of course, arthritis, any form of arthritis, rheumatoid arthritis, osteoarthritis, and so on. And particular of risk is here, you should ask yourself the question, is he climbing ladders, is he working at awkward positions or angles? The same with joint pain, and as we've mentioned earlier, general muscle pains and things as well. All right. The psychological aspect, yes, more so your at-risk guys there, probably more so your shift workers, not being able to spend a lot of time with their loved ones, the underlying depression, anxiety, again, sleep disorders, sleep terribly important. And of course, your security workers. Some of these workers spend long periods of time in isolation, at the facility somewhere, not a lot of interaction, especially a night shift, with other individuals, And then, of course, symptoms of depression and anxiety and so on. All right. There's an extensive list of ear, nose, and throat symptoms, which could be ongoing, tinnitus. Ask yourself, some of the engineering guys, they need to hear subtle changes in the bearing, for instance, on a machine. Does it make a, coarse noise? Is it different to what they normally able to, should hear? And of course, musicians and instrument tuners and so on, where it will definitely affect their ability to work. Okay. Earache, as I say, needing to insert, PPEs. Okay. There might be a feeling that it worsens their earache, sore throat, dizziness, we talked about again. And of course, then we're very familiar with the loss of taste and or smell, with an analytical chemist, a quality control person in a food industry. And where it's important from a safety perspective to have smell, and to be able to smell a liquid petroleum gas leak, for instance, if there's a certain type of welding and things being done. And then there's a whole host of skin rashes. Now those people susceptible to these things will be your you know, the guys working with chemical irritants like your organic solvents. All right. So, you know, the ones that should be urgently refer if you identify these during your medical assessment or your occupational medical examination, you know, include the following. And as I say, as time goes by, you know, I think this list might grow, you know, and that is, of course, severe hypoxemia, you know, and most of the guys nowadays will have an oxygen saturation meter, you know. Severe lung disease, either identified with on clinical grounds, okay, or then if you are doing spirometry and you're able to sanitize the equipment, and you know, at the height of the pandemic and the waves, we ceased to do the spirometry until the risk actually reduced. Then, of course, cardiac chest pain needs to exclude, you know, cardiac event. And remember, the cardiac event and severe lung disease also occur outside of the framework of COVID-19, you know. So under normal circumstances, you would have referred those individuals in any case, okay? Just for the sake of completeness, I've added, you know, a multi-system inflammatory disease in children, but I'll be honest with you, I know nothing about it. All right. So, given that background, okay, how do we decide somebody is fit or unfit or fit with restrictions? Okay. So for each and every job, there is a minimum inherent health requirement for that particular job. That health requirement means the physical attributes as well as the mental attributes of the individual to be able to perform that job. And there are basically two things that we will look at the moment. The one is the capability, and which included the quality and the efficiency, which we'll go into now. But the one is the capability, and the other one is the ability. Now, the capability to perform the task required needs two little tick boxes. The one is the quality and the efficiency. So if we can give an example there, the quality, it may require good vision, like a quality control worker, or fine motor control, like somebody connecting fiber optic cables or repairing circuit boards, you know, something like that, all right? And then as well as efficiency. Now, this efficiency might be the one that could potentially be affected by some of the symptoms listed earlier. For instance, efficiently, the job might require strength and endurance, like heavy manual work, might require flexibility to go in confined spaces, and most importantly also, without undue risk to him or herself or others. You know, as an example, absence of certain illnesses such as uncontrolled epilepsy is a requirement then for that particular job. All right. If we then look at ability to function in working conditions associated with that job. Each and every job carries a risk. Each and every job do have potential hazards. Okay. So the ability is to function in that environment without undue risk to his or her health. Okay. In other words, the absence of certain illnesses that increases vulnerability to working conditions, such as poor controlled asthma in the presence of respiratory irritants, or then, as we've mentioned earlier, respiratory complaints associated with long-term COVID, you know, and it is required that this person perform tasks and functions within that environment. All right. And then the third one is fit with restrictions. So it might be that this individual can perform the work, but needs task restrictions. So you can exclude, for instance, there are dizzy spells, say no climbing on ladders, but the ladder climbing may only be a function that's required for a warehouse, you know, manager or assistant maybe once or twice a day, and he can ask somebody else to perform that job. So that will be then in a task restrictions to say not to climb ladders for the next month. As we've mentioned earlier, it's okay to say, I don't know, get more information. So is it also okay to make the period of fitness shorter and review the individual? If you feel more comfortable by seeing the guy a day later, 5 days later, a week later, a month later, you need to make that call, and you need to feel comfortable with that, and that it is in the interest of the employee, and you can then schedule an appointment for at the date and time determined by yourself. All right. Workplace restrictions restrict an employee from working in certain places. Okay. For instance, hazards posing a threat to the health of the employee, such as chemicals that can irritate the lungs, or requirement for the employee to be under regular medical review, as I've just mentioned. In other words, if there are symptoms that's worrisome, you can ask him to return in a week later and do a reassessment of the individual. Okay. And very important, duration of restrictions or unfitness should be stated. Okay. And in most of the cases, with as far as COVID is concerned, that will be temporary. So unfit means does not meet one or more of the above minimum inherent requirements for the job, not even if any suitable restrictions are applied. Okay. So it might be a little bit small, and it's an extensive list, and I'm welcome to circulate this to all the delegates later on. I'll send you through it in Tlantla, but I've just made made a slide of the top portion. So in the medical assessment, guys, just fit, no problem, no questions asked. If he's unfit, he can either be declared fit with restrictions, temporary unfit, or permanently unfit. And the reason for that can be one of the following 5 categories. There can be an occupational, if we start on the left-hand side, a confirmed occupational disease, a suspected unconfirmed occupational disease, a newly diagnosed chronic medical conditions, a pre-existing uncontrolled medical condition, and not meeting the required medical standard for the job. Okay. So as far as COVID's concerned, it may be any one of the first 3, all right, being responsible for you to make that call and inform the employer that you about your medical adjudication. So the medical examination itself, we'll go through each one of these. It will depend on the type of the job, the medical history, screening tools, the examination, what we call side room tests, special investigations, and maybe additional tests to consider. And I should have added there additional tests and referrals to consider. All right. So the first one, if you go to the first one, also referred to as the so-called man job spec, or more correctly, actually, the occupational risk exposure profile, or as you would know it, the so-called OREP. So the OREP is a document for each and every job type and job function. And it looks at the physical requirements of that particular job. It looks at the working environment. It looks at the exposure of hazards. It looks at safety equipment being provided. And then it should actually also state exclusion and special considerations. And in light of COVID, these documents need to be up-added to include some of the symptoms and things we've mentioned earlier. And it should also then suggested limits or standards required. Okay. Now, I don't know if anybody of you, how often you actually refer to this document, and how many of them are in place, and how many of the employers actually furnish you with this document prior to the medical examination. In my experience, very, very few. Okay, unless it is something driven from the side of the health practitioner. All right. Now, if we look at the medical history, you have the usual medical history, listed right at the bottom. But in light of what's happened during the last year or so, it should include suspected or confirmed acute COVID-19, and specifically mention that as part of the standard medical questionnaire that the employee completes prior to the assessment. All right. But also, they should also look at the nature and severity of previous and current symptoms, as well as the time and duration of the symptoms since the start of acute COVID-19. So it's very important to document the timeline of these things and the timeline of the symptoms associated or brought under your attention. All right. Now, screening tools. Now, for those working in the occupational health space will recognize most of these. So we have tools, okay, like questionnaires. And we use the Epworth Sleepiness Scale for all shift workers and for long distance truck drivers and so on. So in other words, those at risk of falling asleep with disastrous consequences as a result. So we screen them with the Epworth Sleepiness Scale. We also do the Stop Bang questionnaire. Also quite can circulate that, but even if you just Google Stop Bang questionnaire, you'll find a template of that. And that is basically a questionnaire that identifies obstructive sleep apnea. Now, one of the symptoms is a sleeping disturbance. But we can't just say it's a sleeping disturbance as a result of COVID and the guy's got obstructive sleep apnea. So some of these questionnaires could help us to identify the symptoms being listed as are they due to COVID-19 or are they due to other causes? The same with the respiratory questionnaire, which goes into TB and previous episodes of exposure to respiratory irritants, etc., as well as the psychological questionnaire. So these are questionnaires that might come in handy to exclude other causes that we don't just pin this down as a COVID-19 symptom. Now, I think, and it's a personal opinion, I think there's a need for a validated questionnaire for long-term COVID. There is a document which we advised our colleagues in Malawi to use. The healthcare facilities were absolutely overrun by by people with severe COVID, and some of them actually also with less severe COVID, and they did not have the medical resources were stretched and limited, and they did not have a way and a means of assessing, who should actually go to a hospital and who can actually be treated on the, in the rural area. There is a even it was published in the British Medical Journal. There is a questionnaire or assessment tool, I should rather say, called the RECAP, RECAP, and then -V0. It's a wonderful tool, what was validated and so on, to try and look at the severity of acute COVID and then the need for transporting or sending the individual to a medical facility which could actually manage it, in hospital management, I should rather say. And maybe I'll forward that also to Ntlantla, to Bradley Research to send on to you guys. If we look at the side room test, yes, it should include the the physical examinations, all the normal observations that you're familiar with, including oxygen sats. We start doing more and more COVID-19 or SARS-CoV-2 antibody tests, not to make a diagnosis, but to try and see whether that forms part of the picture, and one should take this also into account when making an assessment and so on. So the test on its own maybe does not, mean a lot, but if you take it into account and you take a look at the whole picture, it adds value. All right. And then, of course, the normal urine strip test, the multi-drug test. Again, if the guy uses, substances that affects his cognitive function, we can't just put it down to COVID, long-term COVID, but it might be because he is actually abusing some other substances. Okay, hence the need to actually test for that. All right. And then, of course, these things, audiometry, spirometry, chest X-ray, these are all tests to consider. But when it comes to COVID, and again, this is not me that's so clever or whatever, this is also according to the NICE guidelines, is certain blood tests might be considered. Full blood count, kidney failure, or kidney and liver function test, CRP, ferritin, BNP, thyroid function test, especially if you look at fatigue, you need to exclude hypothyroidism and so on. All right. Now the problem with these type of things is that, if it's, that's why I mentioned right in the beginning, with occupational medicine, you will answer two questions. Is the work affecting my health? In which case, it's easier to motivate to the employer that, you need to have audiometry because there's a noise exposure at the workplace, etc., etc. It's more difficult to answer the question of, do you meet the inherent requirements of the job? And the guy mentions one of the symptoms. Then to try and motivate to the employer, but we need to do an additional test because I don't know whether he's fit, then it becomes very difficult. And then usually this ends up in a referral. Somebody else, carries the cost and not the employer. And it might be a month or even 2 months later on, a delay where you actually first get the answer back before you can do a final determination. A very easy way to look at the exercise tolerance is the example of the 1 minute stand, sit and stand test, and jotting down the level of breathlessness, the heart rate, the oxygen saturation, and how soon this returns to normal. All right. Further additional tests is the chest X-ray, so maybe a psychiatric referral, and then SARS. You might consider even a PCR antigen test as well. And then also, we mentioned before, sleep study. As I say, we make use of a sleep image, which is just a very, very fancy Fitbit type of thing that fits around your wrist. It records your enormous amount of data. The software and the algorithms was patented and is registered in the United States, also with the FDA as a software, as a medical device, but an extremely valuable tool and an immense amount of data that it actually gives. I actually diagnosed 2 dysrhythmias as a result of sleep studies that I've done, and looking at the interactive graphs, being able to identify that this individual actually get rhythm disorders, episodes of arterial fibrillation, for instance, during sleep, and as a result of that, the person actually starts waking up and goes into the unstable form of sleep. That's just incidentally. So all of this, and we're nearly done, provide us with a provisional prognosis or certificate of fitness. And I think in light of all of this, you'll see it's impossible just to say after 15 or 20 minutes, yes, the guy's fit, or no, the guy's fit with restrictions, or unfit for that matter. And I think we as occupational health nursing practitioners and occupational medical practitioners should not be afraid to say, listen, I make you unfit, I need more information, come and see me again in 2 days' time. Or I'm going to refer you to a colleague to get more information. And ultimately, we are the custodians of safety, the safety of that individual and those in and around him that could be affected by this individual. All right. This is just an example of a certificate of fitness. I'm not going to go into detail, listing all the different things. And then I think it's the second last slide. We look at the key recommendations for research. Again, according to the NICE guideline. Okay. Risk factors for post-COVID-19 syndrome, need research on that. What factors, including identifiable clusters of symptoms, influences the risk of developing COVID-19 syndrome, the trajectory of the syndrome, interventions. And I think Dr. John talked about the interventions and diet and all of that. And I'll be keen to have a look at it in more detail once it lands in my inbox. And then, the prevalence of post-COVID-19, the prognostic markers, what is the clinical effectiveness of D-dimer and other blood tests, and the clinical features as prognostic markers for developing COVID-19 syndrome. Develop and validate new and existing screening tools. And that is one that I will be looking out for, just as the Epworth Sleepiness Scale and the Stop Bang questionnaire, to help us to form an opinion. All right. So at this stage, I'd like to thank you for your attention, and I'm happy to take any questions. Thank you very much.
Thank you, Dr. Neil, for that insightful presentation. I was listening through, and yeah, there's quite a lot to digest, and I'm sure as HNPs, there's a lot to learn. Shall we pose our questions? If you have a question or a comment before we close the session, any question or comment, you can raise your hand if you know how to raise your hand through the platform, or you type your question, or you unmute yourself and say out your question. There's a question, Dr. Neil, there by the chat. You can respond to that question. I'm sure if you see it.
I've just opened it here. Is this by Kirsty Stanley?
Yes.
The adjustments made. Yes, certainly. Thank you, Kirsty, for that. Yeah, yes, certainly. It also depends on the type of employer, whether it's a really proactive, engaging employer, and I think they're starting to be more open, and I think that if I can say one of the good things of COVID, if one can say so, okay, is the fact that when they brought out, certainly in South Africa, these comorbidities, and they forced actually employers to start playing an active role in terms of the COVID morbidities that the guys need to bring under the attention of the employer, of course, with their consent and so on. So that certainly also helped a lot, So, but again, I think a lot of the time is because of tradition and history and so on, that that they didn't engage with the healthcare practitioners that much in the past. But it's certainly changing, and certainly it's a process that we need to drive from our side as well, and actually requesting to meet with them, and in my experience, the majority of them, won't say all of them, yes, they are prepared to adjust their working circumstances and so on, especially if you explain it to them why you make a certain decision, and most importantly, of course, with a consent of the employee. For each and every time that we perform a medical examination, even if it's just to do a finger prick on the glucose or any engagement, we ask to get a written consent, either electronically on an electronic medium or written on a paper, and that allows us actually to engage the employer, and we don't need to be scared of disclosing certain items. Yes.
Hi, Tonder.
Hi, Dr. Mpofu. You might want to add.
Yeah, I think it's more of a comment than a question to Neil there. One of the things I want to mention is that COVID, when it it came to us, the speed is of COVID overtaken us, and then I think we're chasing the tail. And one of the things that we should realize is that it's testing the agility of the systems that we have in place, and worse in occupational health, because remember when before COVID, we didn't have anything, even irrespective of the tools that, Niels has highlighted quite a number of tools. We need to readjust and adjust as we move forward. And in the morning, some of the speakers highlighted the symptoms and tracked them, the timelines that were there. Then it shows you that, COVID has also disrupted medicine as we know it, like HIV did in the past, where, the cardiology and pulmonology is separate. But when it comes to COVID, we should have that multidisciplinary approach and work together. But what I want to highlight again is that we're chasing the tail, and we need to chase the tail with very good precision and use the tools that we have in place. Thank you, Neil. Thank you.
Thank you. Thank you very much. I cannot agree with you more, and I think things will still change, but absolutely agree with every comment there. Thank you. Should I go on to Christina's question?
Probably before we forget, Neil, there was a question that you postponed that you said you'll. I'm not quite sure in your presentation, did you address Agnes around pre-med, pre-employment medicals, which she asked earlier?
Yeah. Thank you. Yeah, thank you for reminding me. Okay, if it comes to pre-employment medical, it's easier to actively manage these cases if it's already employed. But remember that when it comes to pre-employment, okay, usually, unfortunately, in an environment where we have got a lot of unemployment, there is a lot of other guys standing in line. So the sad reality is that if that individual there and then is unable to perform or to meet the inherent requirements of that specific job, there's usually somebody else that will take the place, and the employer is really willing to wait. So during the first time of the assessment, is the individual, and you require more information, and there are all these symptoms, you, depending on the type of work, whether it's an office work, whether it's an administrative work, whether it's a physical work, you need to make the call. But and if you're unsure, you should be led by your experience and by your gut feeling and what you know. And if you're unsure, then rather postpone to say, listen, I'm unable to make a determination now. I'd like to see the individual again a day or two, a week later. But in most majority of the time, the employer will say, but in that case, we want the position to be filled like tomorrow, So there is a little bit of a dilemma under those circumstances, yes.
Thank you, Neil. I think you might go to Christina's
regarding the occupational therapist.
Yes.
I think, as I say, if you, we need, I'm just speaking from a personal point of view. I usually make use of an occupational therapist, and they do marvelous work, excellent work, when it is more long-term story. In other words, it could potentially affect the employment status of that individual in terms of incapacity, incapacity due to ill health, losing a job. And I think we owe it to that individual then to say, and meet with the employer to say, listen, this is a situation, I recommend that before we just, file for incapacity due to ill health and terminate employment with this individual, that we should actually try and get an occupational therapist report. Okay. For short-term illness, short-term meaning even 1 month, even sometimes 2 months and so on, and where the reason is obvious and where there is progression and an improvement, I don't request an OT report. But certainly if for instance, it's somebody on renal dialysis and it's expected to remain the same, or at least then, well, hopefully not, but if it deteriorates over time, that will be an OT, getting them involved. All right. Let me just have a look at the second part in the chat box there. Able to explore yeah, now I absolutely agree with you, Kirsty. I think the majority of, and I'm including myself there, and it's nobody's fault really, poorly understands the field of occupational therapy, the assessments that you conduct. We basically page through the document, providing a comprehensive document on something, and then most often or not, some of the guys just page to the large page, to the summary and so on, not understanding everything. And I think there is a need actually for, and it might be a topic for Bradley research on occupational therapy and what you actually can offer, employees, and especially employees that needs work accommodation. All right. I hope I've answered the question.
Thank you, Neil. I don't see any other question. We might have to conclude. Probably we need to think deep around the potential impairment and how we do the impairment assessment from long COVID. Probably something that as occupational medical practitioners you might have to think about and advise going forward. I'll give Dr. Mpofu his closing remarks, and then I'll give you, Neil, to close off. Dr. Mpofu, your closing remarks, and then we give to Neil, and then we close the session.
Ntandla and colleagues, this was a very informative session, and then let me say all sessions since in the morning. And again, it just highlight how we need to interact continuously and talk about this. And then, as a multidisciplinary, where we are sitting, we can really do something that is positive for our patients, positive for the industry, and positive for respective countries where we are. But again, Neil, thank you, and all the guys who did the presentation. As we go forward, we'll see some light at the end of the tunnel. Thank you. Bye.
Okay. Neil, your closing remarks.
Yeah, thank you. First of all, thank you for the initiative on Bradley Research and Ntlantla yourself and getting all the colleagues together. Yeah, the old phrase, we live in strange times, things are changing. We start using, if I just look at our WhatsApp groups asking, exchanging information, here in the Western Cape, we formed a WhatsApp group started by one of the occupational nursing practitioners. And I think we're sitting on 85 at the moment. So we're using technologies just quickly to share information and to learn more. And this will certainly be a field that we will learn more and more, as time goes by. Secondly, we need to start thinking about alternative ways of assessing individuals, and hopefully we'll have the additional screening tools to do so, because at the end of the day, we as healthcare providers need to put food on the table. And unfortunately, although we would love to spend the whole morning doing an assessment, on a individual fit for work, we cannot do so. So all of these tests and things and so on, they are time consuming. In the meantime, we need to assess 10 or 20 people or whatever a day, and so on. So that makes it very difficult. So hopefully, in time, with apps, with electronic health platforms, with validated questionnaires and so on, things will improve and speed up the process a little bit, as they've done with other conditions as well. And I've mentioned for instance, the HIV dementia scale and so on. Yeah. So yeah, it will evolve. And so lastly, I'd just like to thank everybody for your attention on a Tuesday afternoon like this. And anybody, you're more than welcome to get in contact with me. And stuff that I've mentioned, I will forward it to Bradley Research for distribution. Thank you very much.
Thank you, colleagues. Thank you, Dr. Neil, for the time. And thank you for always being a part of Bradley Research. We've worked together quite well over the year. So thank you for being a part of us. Just a few things before we close the session. First of all, you'll be getting evaluation forms for this particular program. So you'll evaluate the content, also evaluate the speakers, so that we might improve our offering as we go by. So we'll send that tomorrow. It will be in your inbox. Your certificates, you'll be given your certificates next week. So are the recordings. But the presentations, hopefully we'll have all the presentations sent to you by tomorrow, including the NIST guidelines, which I think Dr. Neil has emphasized more on that. They will help us shape our environment and hopefully improve our systems. If you do not have my email address, I'm going to type my email address on the chat group. It's in small caps, even though I know it will appear, my name might appear in capital, but so please send me an email if you do not have my email address, so that I'll be able to send you the presentations and all the recordings. For now, thank you so much, colleagues, for the day that we have spent together. We will hopefully engage in our next session mid-March, towards the end of March, where we want to talk about human resources and their understanding of COVID-19, of post-COVID, so that we might see how we deal with issues around sick days, incapacity, and impairment, so that we give our HR people some knowledge around how we do assessments for these particular conditions. So for now, thank you. We can go back to our workplaces, check our emails, respond to 1 or 2 emails, and then tomorrow you will engage as we send these evaluation forms and presentations. Thank you to all the speakers for your time and preparation. We do appreciate all your work. Thank you.
Thank you very much.
Thank you.